Well, thank you all. I have to say the pleasure is truly mine to be here. I've been for a long time, I realized that my path was out here, and I'll kind of explain more about that as time goes on. So the fact that Brian, the department, were able to bring me out here is just a real joy and pleasure for me. Today we're going to talk about the EEG as a biomarker of brain vulnerability. But I hope actually the endpoint of this is that you get curious about what's happening in the brain and try it out. I am an inventor on a few patents assigned to Mass General Hospital related to brain monitoring. I'm also a co-founder of a startup company, Pascal Systems, which is developing technologies to aid anesthetic management. But the support for this research has all come from the NIH, previously also from the department at Mass General, and currently from the department, our department here at Stanford. I'm not a real doctor, guys. So I'm an engineer, so, take everything with a grain of salt. But actually, I spent a lot of time, with you all in the operating room. There's a picture from about 10 years ago now with myself and Emery Brown, and also a reporter from NPR named Tim Howard. We did a piece on Radiolab. It was kind of last minute also. Like, this is we were about to leave for Hawaii, my wife and I, to get married. She was my fiance then. And I was able to fit this in, and it became a Radiolab piece. It actually aged well. It's still on the radio now. So every once in a while you'll hear me. But I think this picture says a lot of things, and one thing I do spend a lot of time with you all in the OR, and so I hope that I bring some interesting third person perspective to what you guys are doing and can contribute in that way. But as Brian mentioned, I'm working on neuroscience, signal processing, mechanism of anesthesia. We'll get into that a little bit today, but today we're going to mostly focus on perioperative brain health. Okay, so let's take a look at an EEG. This is an old school SedLine from the late 90s, and for a long time this is all we had at Mass General. So we're looking at 4 leads from the forehead of a patient who's about to get propofol to induce general anesthesia. Every one of those tick marks is about 1 second of time, and you can see little deflections there, which are eye blinks. And then right about now, there's a electromyogram artifact that appears in the bottom trace because, when you administer the propofol, it can have a burning sensation. So that EMG is kind of taking over. So still some eye blinks. Now you start to see a little oscillation. It's called a beta oscillation, which is slowing down to about 10 hertz, an alpha oscillation. Now the eye blinks went away, and now we have this slow oscillations, about 1 cycle per second. The EEG is getting slower and slower. And when that slow oscillation appeared, the patient was unconscious. Now we have this flat section, okay? That's called burst suppression. That's the brain is literally silent for seconds or more at a time during that suppression period. And that is beyond what you need, let's say, to maintain unconsciousness. And if you go into any OR anywhere in the world that is, say, inducing with propofol, and you put on the EEG, this is the cascade, the sequence of patterns that you are likely to see. And actually, if you go more often than not, they'll be hanging out in this burst suppression pattern, which we'll get to a little later. So we saw a couple different things: a beta alpha oscillation, 12 to 25 hertz, slowing down to 8 to 12 hertz. It is associated with a sedative state. I'll explain more about how we know that later. Just a moment later, this slow oscillation developed underneath the alpha oscillation. It's associated with an unconscious state. Again, I'll explain a little bit more how we know that. And then burst suppression. This is something you see in people that's, let's say, have anoxic comas. And again, something beyond what you need for unconsciousness. So we were seeing oscillations in the brain with this EEG. Why are oscillations important? Why do they even matter? Okay, well, they're fundamental actually to brain coordination, right? The brain has all these moving parts. I don't know how many tens of millions or hundreds of millions of neurons are in the brain. How many, hundreds of different nuclei and regions. They all have to be coordinated in some way to kind of function purposefully to do, any of the things we do, right? the oscillations are also clinically visible, but they coordinate brain activity. So check out this. Oh yeah, good. Check out this alpha wave here, which is like the one we saw on the EEG. This is inside the brain in the thalamus of a cat. Really a ubiquitous thing for controlling thalamocortical sensory processing and also prefrontal processing. Underneath that, we can see a trace of a single neuron being recorded at the same time. And, you know, look, it's quite clear. If there's certain phases locked to the overlying EEG where the neurons can fire, and others where the neurons cannot fire. And that kind of clocking mechanism keeps everything engaged and in synchronization across this whole, you know, wonderful complex brain that we have. So if these oscillations are really fundamental for organizing brain activity, if we were to give, you know, powerful GABAergic agonists, powerful alpha-2 adrenergic agonists, you know, NMDA antagonists that are slowing down or blocking neural activity, we could imagine that we might throw off this timing. And that is what, you know, I and others believe is a fundamental mechanism for how anesthetic drugs produce and maintain unconsciousness. It's there staring us in the face if we would just bother to look at it. And these oscillations under anesthesia are the biggest ones, among the biggest ones you'll see in the universe, if you will. They're as big as you know, activity you might see during seizures, just to indicate how powerful they are. So let's just talk a little bit about mechanisms of anesthesia. We saw propofol induction, and we saw that raw trace. That's old school way of looking at the EEG that we inherited from neurology going back to the 1930s. But if we were to just analyze this a little bit more, nothing too complex, but if we were to break down those waves into the fundamental components, we might see, you know, one component that's that slow oscillation about 1 cycle per second, and then that overlying alpha oscillation about 10 cycles per second. We can just count it out: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And we could very readily see what's going on. On the other hand, if we wanted to be a bit more quantitative, rather than using calipers, we could actually analyze this data and break down the amount of energy in every frequency and actually do that as a function of time. So here we have about 20 minutes of time on the x-axis, all the frequencies going from 0 to 40 hertz. And we are measuring the amount of energy in the signal with this color decibel scale, right? So it's like the Richter scale. So we're getting quite large oscillations from the quite a large dynamic range of oscillations from the ends of this color scale. So blue colors indicate very small or non-existent oscillations, whereas the red colors indicate something that is large, so a lot of energy. And we can see that, okay, well, here's that slow oscillation. Let's map that to about 1 cycle per second. Boom, there it is. Here's that frontal alpha around 10 cycles per second. And that jives our intuition for what's in the signal. And we can see that's kind of the only thing going on, all right? Now, what does it mean? How do we interpret this signal functionally? So I like to think of it maybe in musical terms. So the brain, if you will, in its natural state, kind of needs to process a lot of information. If we look at this EEG signal, we can think of low notes, you know, the slower things as low notes on a piano keyboard, the faster things as high notes on a piano keyboard. And the brain kind of needs all the notes in the keyboard to communicate normally, right? So with propofol, what are we doing? We're taking away a bunch of those notes. It's only got 2 notes, bom, bom. You know, normally the brain wants to go do da do do da do do da. It wants to play with all the notes, but here it only gets 2 notes, bom, bom, something like that. All right, what do those 2 notes mean? So that upper note, we think reflects a disruption of thalamocortical processing and prefrontal processing. So prefrontal cortex, you know, executive function, working memory, cognition, right? So that's just down to 1 note, right? Bah, that's all you get. Normally you want to play with all the notes, but you just get that 1 note. So of course, we can infer that those prefrontal functions are disrupted. How about that slow oscillation, okay? So here we were able to study many years ago now in human patients that were receiving electrode implants for epilepsy diagnosis and later surgery. So those folks got EEGs implanted intracranially. They also had these research microelectrodes that allowed us to record tens to dozens of individual neurons in the cortex. And when they had to come back to the OR and under general anesthesia to have those electrodes removed. So my team was able to come in and record from those electrodes during that transition to unconsciousness. All right. And I'll just tell you now before I forget, you're going to see my team in the OR in the coming months doing various things. And my pledge to you, my solemn pledge to you, is that we will not be a pain in the ass. All right. So you can imagine, like at this time, like we had like a neurosurgeons staring over us. They didn't know me. I mean, kind of like, hey, come on, man, hurry the hell up. But we were able to conduct this experiment and everything that followed in a way that did not interfere with clinical care. So that's my pledge to you, not a pain in the ass. So what did we learn? All right. I mean, okay, at baseline, we're recording from these neurons. You can see the overlying EEG here. All the notes are, visible in that EEG. And then underneath that, there's a raster of these neuronal spiking, okay? And the frequency of neuronal spiking, so every one of these black bars indicates that neurons are firing. So this seems great. All the notes of the keyboard, neurons are firing. So if we were to go back to that musical analogy, it might be something like, come fly with me, come fly, let's fly away. If you could use some exotic booze, there's a bar in far Bombay. Something like that, all right? But then moments later, the propofol is administered. We see that slow oscillation that you all saw on the EEG, ubiquitous, okay? And you can see that right here. Notes the keyboard, only a few. And what's going on with the neurons? They're only able to fire intermittently, once every like 2 seconds or so. So a little burst of firing, and then there's a silent period, burst of firing and silent period. So that silent period, no neural activity, no processing of information in the cortex during that time. So what would that be like in musical terms? So it'd be something like, come away. If you, some exotic, there's a bar, you can't process the information. It's attenuated, right? The information is sort of diminished in that state. And so that's why we can infer when you see that big slow oscillation that consciousness is disrupted. And there'll be much more to say about this. I mean, we have in the lab, I have a whole kind of very simple actually theory on how to break this down and advance our understanding of this to where different functional systems in the brain, arousal, sensory processing, cognition are all disrupted in different ways by different anesthetic drugs. And we can just basically measure that, characterize it, literally see the brain sort of ceasing in its ability to process those functions. We're going to do that right here at Stanford. So you'll see my guys and gals in the OR with you exploring that together. So other drugs, right? Other neural circuit mechanisms, other, neuropharmacology. So with ketamine, we're inhibiting an NMDA synapses, inhibiting inhibition, allowing activity to sort of be disinhibited to increase. And so there with ketamine, the song is a little different. It's sort of like maybe Flight of the Bumblebees, high frequencies, something like that. With dexmedetomidine, we're engaging sort of an endogenous sleep mechanism, producing something that looks like a slow wave or stage 2 sleep. So with dexmedetomidine, you see a little bit of a slow wave, but you see this kind of intermittent spindle, right? It's not there all the time. It's intermittent. So it's like one note, intermittently, one note, something like that. And then with propofol, we have that bum, bum, just that constant drone that is inhibiting activity in the brain. So over the years, we've kind of studied, let's say, that propofol component, also similar to sevoflurane, where if you increase the concentration of propofol, let's say, we see that slowing from, let's say, gamma frequencies, say 20 to 40 hertz, all the way down into that alpha range that we saw earlier, okay? And through computational studies, we started to understand that what's happening with that alpha frequency is that we're really slowing down this thalamocortical circuit. And then later on, is with computational models where we have like digital propofol, increasing, the inhibition in the computational model. And then we did recordings in rodents where we literally had electrodes in rodent prefrontal cortex, rodent thalamus, and showed that indeed that alpha activity happens in that prefrontal thalamocortical circuit. And we're going to look at how that changes now with aging, okay? And so, yeah, do these brain oscillations have anything to do with cognition? So I've talked about prefrontal cortex. All right, so let's take a look at kind of the logic behind this, all right? Here's an example of a cognitive task called set shifting, where you have to process the context before you kind of engage in the actual cognitive computation, if you will. So in non-human primates, in this example, they're presented with a screen where the border lights up first, and depending on the color of the border, it tells the non-human primate like what they need to do with the subsequent stimulus. So if there's a magenta border, the primate has to pay attention to the color of the subsequent stimulus. So they're like, okay, magenta, okay, I got to pay attention to the color. Oh, red, oh, it's red. Okay, so now I'm going to look left to get my juice reward. Nom, 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 nom. All right. If instead the border is blue, okay, I got to pay attention to the orientation. So if the next stimulus is like vertical, I got to look right, and then I get my juice reward. So that's the task. And actually, we've coded up an auditory version of this that we're going to use in the OR. All right, to see this whole process that I'm about to show you break down in real time. So what happens? Okay, so when the rule is presented, that magenta or blue border, what happens is the prefrontal cortex activates in this beta or gamma, let's say gamma, 20 to 40 hertz frequency range. And it needs to do that, it needs those notes of the keyboard to be able to set the context for the later processing of that stimulus. So it's an executive function, okay? And it turns out that actually GABA inhibition is critical for maintaining that range of frequencies. So this is an example of, in a computational model, of an excitatory neuron and an inhibitory interneuron, all right? And essentially what happens is that when this excitatory neuron activates, it actually excites this inhibitory interneuron, and there's this kind of push-pull back and forth. So there's excitation and then inhibition, and then excitation and then inhibition, back and forth and back and forth. And the fundamental frequency at a gamma or 40 hertz-ish range is set by the time constant strength and the time constant of the GABA synapse. So you can imagine if the synapse is really, really strong, really inhibiting things, then it might take a longer time for the excitation to come back, right? So that's how this circuit sets the time constants, through inhibition. All right, and so you can imagine if you were to, mess with inhibition, make it stronger, slow down its decay time, you could slow down the timing of that circuit. So that's why we're, able to hypothesize at this point that if you slow down that circuit into alpha frequencies, the circuit should not be able to perform its function, and this empirically, right? People aren't like doing complex cognitive tasks when you put them under propofol, right? And that I think is why this is happening. But we're going to really test this hypothesis in the OR, coming to an OR near you, and not a pain in the ass, let me add. Okay, so does this tell us anything about the anesthetic requirements of, say, older patients? All right, so let's take a look at how this EEG that I showed you changes with aging. So here's a 30-year-old patient getting propofol for maintenance of general anesthesia. So we see this combination of slow and alpha waves, that prefrontal alpha waves that we looked at earlier. So that's a 30-year-old. Here's the color scale. It's going to be the same color scale as we go through. Here's a 57-year-old patient. Okay, it's the same thing. No surprises. What about an 80-year-old? So here's an 80-year-old. Okay, it's obvious that this is a much smaller EEG signal. If you kind of were to zoom in, you could still see this alpha wave, but it's actually faint compared to, even after you zoom in, compared to, say, a younger person. And not everyone ages the same way. So here's a 56-year-old who kind of looks more like the 81-year-old. All right. So there's a lot of variation in what this alpha wave is doing. And then interestingly, Here's a 3-year-old and a 14-year-old. So we think the size of this alpha wave relates a lot to the synaptic density. I don't have it in this talk, but there's these post-mortem studies of synaptic density, and it seems to line up with what we know about the size of this wave during development. But yeah, synaptic density, well, it can get lower through age. So yeah, there you go. So you might infer that this 56-year-old in the middle has kind of an older brain. You might infer also that if this is coming from the prefrontal cortex, that maybe their cognitive function is a little impaired. So let's take a look at that. So where does this EEG come from? So I said prefrontal cortex. We actually at some point localized, kind of triangulated where this was coming from in humans using a high density EEG. That's also coming to an OR near you, but again, not a pain in the ass. So we localized it to this, say, medial and dorsolateral prefrontal cortex, and a little bit to, say, anterior cingulate cortex. And if you compare those regions to those that show, say, cortical thinning, aka neurodegeneration, during aging and Alzheimer's, they do kind of correspond. So it sort of implies that what we might be seeing here, this is years and age. This is age in years now, time in years. So 18-year-old patients all the way up to 90-year-olds. We might infer that this diminution of the EEG is actually telling us something about underlying neurodegeneration. So in 2017, Miles Berger's group did a analysis of EEGs and showed that this intraoperative alpha power correlated with preoperative cognition. So when the alpha power in the OR gets lower, so too does baseline cognition, right? So consistent with this picture, we're seeing something that relates to cognition. There was a follow-up study, Gutierrez et al. 2020 also showed something very similar. And here, you know, this MoCA score, right? Like about 3 or 4 points on a MoCA score starts to put you into a range of a mild cognitive impairment. And you can see that on the EEG. 5 decibels on the EEG is actually big. You can see that. You can see that in the OR, right? So the EEG is actually a pretty sensitive instrument for kind of telling you what the patient's state of cognition is. We talked about burst suppression, that state of a comatose brain, if you will, that again is beyond what you need for anesthesia. So it turns out that this alpha power is predictive of the likelihood of a patient going into burst suppression. So just a 1 decibel decrease in alpha waves. So you can't really see that with the naked eye. That increases the odds of going into burst suppression by, say, 25%. As an example, you know, here are 2 older patients from this cohort of about 100 patients that we looked at. Someone with a strong alpha wave, you know, they're just going to maintain during anesthesia. But with this smaller alpha wave, you know, they can come in and out of burst suppression. And it does seem to suggest then that the people with the smaller alpha wave maybe need have lower anesthetic requirements. Further to that point, this next slide is kind of complicated, but I want to get through it, and you know, we can talk more about it later. But this is a study of maybe about 40 or so, I forget exactly, roughly 40 patients who were receiving sevoflurane for maintenance of anesthesia. They were all getting, you know, the same age-adjusted MAC, but Gutierrez et al. Looked at the MoCA scores and split them up into a low MoCA or a high MoCA group. So the low MoCA group is sort of getting into that mild cognitive impairment range. And so what did he find in the EEGs of these low versus high MoCA people? So it turns out that the people with the low MoCA had a kind of depressed alpha wave and an alpha wave that shifted a little bit to the left, to lower frequencies. They also seem to have higher slow oscillation power. So that combo of alpha wave shifting to the left to lower frequencies, higher slow oscillation power, that is kind of consistent with a deeper state of unconsciousness. So they got the same MAC, but the brain is more deeply, you know, unconscious. And further to this point, we did this, this is a lot to cover in one lecture, but we did this thing called phase amplitude modulation. And basically, phase amplitude modulation, when it's more red here, it means that there's kind of more silencing of neuronal activity, all right? So deeper red, more silencing of neural activity. So the low MoCA people are again, more deeply anesthetized. So, oh man, the font didn't really scale well. So basically, these people with the lower MoCA, they actually had a longer emergence time by maybe about 5 minutes. They had all the signs of a more deeply anesthetized state, even though the MAC fraction was the same. Okay, so the picture that's emerging is that, hey, everyone's a little different. Everyone ages a little different. People may be sicker. This isn't necessarily a permanent thing. If you actually cure their cancer or something, maybe this all comes back. So if you got a young brain, everything's fine. If you got an older brain, more than likely you've got lower baseline cognition, smaller alpha waves, more likely to go into burst suppression, lower anesthetic requirements. All right. So what does this have to do with maybe predicting an post-op outcome? Let's say post-op delirium. All right. So now let's take a look at this. So it turns out that people who go on to develop some form of delirium, it could be a subsyndromal delirium, but some aspect of delirium, some disruption of arousal, transient disruption of arousal, some transient disruption of cognition, right? Those folks who go on to develop delirium, they actually have smaller alpha waves in the OR, right? So if you see one of these patients that's got a small alpha wave, maybe in the future, the PACU could be alerted, the floor could be alerted to kind of pay a little more attention to this patient to keep them out of that delirious state. Because I'm sure you guys remember from your time in med school or internship, those folks, when they go into delirium, they don't really come. They can stay there for a while. It increases length of stay and has bad prognosis for their long-term cognitive outcomes, their long-term functional outcomes. All right, so here's another study also looking at the alpha wave, and you can see the folks on the left here who go on to develop delirium. They have a smaller alpha wave intraoperatively than those who did not go on to develop delirium. Okay, and let's see. So I'm halfway through here. So I just want to mention burst suppression, that pattern we saw earlier with where the activity is sort of EEG is like flat, and that flatness small signal corresponds to blue here on the spectrogram. We'll come back to that a little later. There's evidence that as you increase the amount of time that you spend in burst suppression, so does the incidence of delirium. So at the end of the day, can EEG predict postoperative neurocognitive disorders? And I would argue yes. Like certainly a pre-op assessment of cognition would be important. But if you see burst suppression, lots of literature showing how burst suppression correlates with post-op delirium. If you have smaller alpha waves, that goes on to predict a post-op delirium. And then if you have either smaller alpha waves or lower pre-op cognition, that also suggests that you're going to have lower anesthetic requirements and then go on to have higher likelihood of delirium. But yes, the EEG can help us predict who may go on to have delirium. All right, now, is there evidence that EEG guided outcomes, EEG guided anesthesia care could improve outcomes? All right. Well, this is kind of a mixed bag, but it's still early days. All right, so in I think it was 2013, Matthew Chan and colleagues did a study of BIS-guided anesthesia, and they had two groups that were either routine care, no monitoring, versus a BIS, where they were instructing people to maintain patients between 40 and 60 on a BIS. Good sample size, right? And the primary outcome was 3-month postoperative cognitive dysfunction. Secondary outcome was delirium in hospital, say in the first 5 days post-op. I thought I turned okay. And so here were the results. So people in the BIS group had a significantly lower incidence of delirium, so 15% compared to 25%. They had a lower rate of postoperative cognitive dysfunction, so 10% compared to 14. So overall, EEG guidance in this study reduced post-op delirium by about 35% from that baseline of about 24%. So then in 2019, there was this study called Engages, published in JAMA, basically very similar design, but they didn't find any difference between the control and EEG guidance groups. And there was a smallish difference in the actual MAC fraction between the two groups. So the treatment group had 0.69 MAC. The usual care group had 0.8. I mean, that's not a huge difference, but in the end, they concluded that they could not support EEG guided anesthesia to reduce delirium, and it's published in JAMA. So of course, people took it to heart. So in retrospect, if you just look at the data in these studies, comparing, say, the CODA study and the ENGAGE study, in CODA, there was actually significant difference between the two groups in terms of MAC fraction for maintenance of anesthesia. So here we're going from about 0.9 all the way down to 0.5 something for CODA. For ENGAGES, the gap was quite different. So they didn't really have a substantial difference between the groups for the treatment. Okay, and then if you look at the amount of time spent with BIS less than 40. In the two groups in each of the two studies. And here, BIS less than 40 basically means more than likely burst suppression, because that's how the BIS was designed. And in the CODA group, per hour, there was very little time, maybe less than 5 minutes of time spent with BIS less than 40. In the routine care group, it varied quite a bit. In ENGAGES, both groups spent a fair bit of time with BIS less than 40, and the two groups overlapped a lot. So it's as if they didn't do a great job of kind of maintaining quality control for the EEG guided group. Another shortcoming with the ENGAGES study is that they didn't measure post-op delirium in the first day, right? If you were hypothesizing that anesthesia was doing something, you'd kind of expect it to be happening earlier on in the course, right? And the European Society of Anesthesia, gave this guideline way back in 2017, saying that you have to really start on that first day with measuring delirium to kind of really get a good assessment of delirium. And they didn't do that in the ENGAGES trial. So fast forward now to 2021, there was a branch of the BALANCE trial by Liz Everett, Tim Short, and colleagues, where they randomized between a high and low BIS group, so lighter and deeper states of anesthesia, and about 500 patients overall. And in this study, what they found is that in the BIS group, delirium was significantly reduced to 19% from a baseline of 28%. 1 year post-op cognition was better in the high BIS group, the light anesthesia group, and they had a sizable, a larger gap in the MAC fraction. And here in this study, what they found was that the biggest difference between the high and low BIS groups was occurring on post-op day one. So the low BIS group here has a lower incidence of delirium and that post-op day one. And again, that makes sense, right? If you're looking at anesthesia-induced effect, you expect that kind of happening sooner. Once they get onto the floor, they're out of your hands, and all kinds of other stuff is happening. And in a follow-up meta-analysis, they find that even after you take into account all these studies, including ENGAGES, there's an overall net positive effect of reducing delirium by using, let's say, EEG or BIS. All right, so why don't we use EEG routinely in the OR? What are the barriers? All right, I remember someone in a review article saying it was too expensive. It's $10 to $25 a case. I've been on planes. Back in the day when we used to travel a lot, I'd sit next to someone and you'd have the conversation. Oh, what do you do? And then I'd ask them, hey, how much do you think it would cost to monitor someone's brain under anesthesia? First of all, I asked them, where do anesthetic drugs work? And they would figure out, they knew it was the brain, all right? And we don't monitor it, but everybody knows it's the brain. I then asked them, hey, do you think people monitor the brain? And they're like, oh yeah, of course. And then I'd ask, hey, how much do you think it would cost? And it'd be like, estimating in the hundreds of dollars, right? That makes sense. No, it's $10 to $25. What about the equipment? It's free, right? Or it's $4,000. As a capital expense, this is de minimis, right? Okay, what's the cost of delirium, all right? Incidence of delirium is 25% in patients 65 and older. What's the cost of delirium? It's around 44 grand per occurrence per year in Medicaid care, right? And for the I guess better payers, right? The private payers is probably more, but for Medicare, it's 44 grand, all right? So then if you take a look at the different trials, like CODA, you can reduce delirium by 8%, BALANCE, you can reduce delirium by 9%. In a meta-analysis, you can reduce delirium by 4%. That's like 3, 4, maybe 2 grand of savings per patient just from putting on an EEG and titrating the anesthetic downward, right? And the cost of the sensor is 10 to 25 bucks. If you want to save some money, you should use some EEG. But even people in our field, like they will write editorials saying that, oh, it's too expensive. All right. So what are some of the shortcomings of existing EEG technology? There are a lot, all right? And part of the reason I came here was to kind of get after this, okay? So one of the things is that it's kind of a simple, oversimplified construct, right? A lot has happened between the 1990s and today. We know a lot about how the brain works. And this is a bit of an oversimplification, just to boil it down to one number between 0 and 100. The other problem is that number doesn't actually work. That creates problems, okay? The BIS was originally trained on young patients in their 30s, and they've got this perfect EEG with the big slow waves and the big alpha waves, and this is an easy signal processing problem, right? You get into these elderly folks, they don't have an alpha wave, and at this scale, it looks like an awake EEG. So if the monitor expects to see that and it sees the other thing, well, the index won't be accurate, and it might, because the EEG just doesn't have anything going on, especially in the alpha wave, the BIS might read the EEG as belonging to someone who's awake, all right, even though there's some alpha power there. So, and then if it reads as if someone is awake, the index will be high, and then the anesthesiologist will be, compelled to increase the anesthetic exposure to bring the number into range, right? And that would then perhaps lead to higher incidence of burst suppression, because if you can't see the alpha wave, the other thing that the BIS can see is the burst suppression, all right? And so that's the thing that you have to work off of in these old brains if you don't have an alpha wave. So turns out that actually there's evidence that this story holds up. So in this study by Besh et al., people were maintained on a BIS between 40 and 60. I think they might have used feedback control for that. So they really, really made sure that they were in 40 to 60. All right. And then it turns out that the folks between 60 and 80 years of age, they were 4.8-fold more likely to be in burst suppression than, say, younger folks. If you're 80 or older, you were 10-fold more likely to be in burst suppression, right? Because that's all the monitor has to go off of. It doesn't know that it's an old brain. So in these older folks, the BIS is biased towards burst suppression, and it still produces a good outcome, right? I mean, that's kind of amazing, but it is biased towards this excessively deep state of anesthesia. So for older folks, what I used to do at Mass General is just teach people to use that raw spectrogram, that raw EEG, because if you adjust the scale, right, you can see those waves and feel more confident that you're reading the right thing in the EEG. So in summary, these alpha-induced EEG oscillations relate to underlying cognition, and they diminish with age. And the smaller alpha waves are predictive of postoperative delirium. And there is growing evidence that even with a totally imperfect tool that we have now, and it's just old, look, things should change more often, right? If you develop something in the 90s, there should be a few updates. We don't see that yet. We're working on that. But it's 2023, right? We're due for an update, right? Finally, an update. And things will get better, even with things will get better. We'll have a better device, and this evidence I predict will improve for utilization of EEG to improve outcomes. Okay, so I came out here to have interviews. A lot of you here that work here, you went through this experience. So you sit down and you're having a conversation, and it starts off. So why do you want to come to Stanford? Right, and so. I don't know what I said, but it was long-winded. But I think to boil it down, why did we come to Stanford? So I think to boil it down, in Boston, we learned how to understand the present. We learned that very well. But at Stanford, we're here to create the future. All right, that's why we're here. And here's the present and the adjacent future. And there's a lot of adjacent future we get at, but this is what I could come up with overnight. Okay, so we need a lot of training and education to teach people how to use the EEG well and have it not be a pain in the ass. But that's an opportunity for us to innovate in education, in patient safety, and to really make anesthesiology a neuroscience discipline. Okay, the process EEG needs to be updated, right? It was last updated in the 90s, all right? But this is a really tractable problem. And even today, we can learn to read the EEG. You know, you guys are the best of the best, right? You guys can do it, okay? We're not able to, say with older generation technology, monitor nociception or opioids. Also a tractable problem. In 2022, we published a paper describing the opioid EEG signature. So now, you know, you can, if you squint, you can see it. Newer technologies will put that into play. Clinical evidence is mixed supporting the use of EEG, but better technologies will be on the way and better education. I think we'll be able to really make best use of the EEG to kind of optimize outcomes. So we've got 15 minutes left. How about some case studies? All right, let's do some case studies, then we'll leave time for EEG, okay? All right, so first of all, let me teach you a little bit about the EEG. So here's a patient, actually, I think this patient, I get that all the time. This is a patient, I think this is like a 9-year-old, it's a child who's maintained being maintained under general anesthesia with SIVO and nitrous, okay? And then in the next screen, the SIVO and nitrous are turned off. All right, and what do we see? So SIVO behaves a lot like propofol. So here's this kind of ascending frequency, right? It's the opposite of what we saw with propofol when propofol concentration was increasing. So SIVO concentration are going down. So the notes of the keyboard are coming back, and then eventually the patient wakes up. All right. So just pay attention to this, that increasing frequency going from like 10 up to 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, right? All right. All the notes of the keyboard coming back. And then just a reminder, here's burst suppression again. So these flat segments, like brain is silent, it's flat, silent, you know, like flatline EKG, this is a flatline EEG, all right? And the flat segment corresponds to blue on the spectrogram. So small, right? Low power. All right, so now let's take a look at a 9-month-old who's getting a ureterouterostomy. I said that right. If we look at the time scale here in minutes, the surgery's been going on at this point for about 3+ hours. Maintenance with SIVO and nitrous, but they received a caudal anesthetic at the beginning. And I should mention for all these cases, you know, we're kind of under a Star Trek like prime directive situation where my team can be there and record the EEG, but we can't like be giving people advice, you know? So, you know, yeah, my CRCs want to be you when they grow up, but they're not you yet. So, you know, I was here for this case actually, and this wasn't at MGH, it was somewhere else in Boston. Heart rate, okay, blood pressure, EEG. And this is SIVO with nitrous in a younger kid. So we see that alpha wave, we also see this beta activity because nitrous has an NMDA mechanism that kind of has those high notes, you know, the flight of the bumblebees going on. So you put them together, you get more high notes. All right, so let's see, let's move forward 10 minutes or so, all right. Anything, what do you guys see? Is it running out? Yeah, I think actually the SIVO hasn't changed at this point. That much I know, but something's going on, right? So if the SIVO is the same, then what might you infer? Yeah, yeah. And unfortunately, the anesthesiologist could not see this. Like they weren't trained in this. This wasn't how they're trained to do anesthesia. Okay, great. You guys are good. All right. Now what's happening? SIVO is the same. All right, it's more of the same. All right, I don't mean to make you repeat yourselves. All right, anything else actually beyond the EEG of note? Yeah, heart rate's going up. Yeah, I know. Dun, dun, dun. All right. All right, so at 1 here, the patient moves. And then at 2 here, the anesthesiologist gives propofol to cease movement. And I forget what it was, but it was a lot for a 9-month-old. We have a case study. This case study is written up. And then what happens? Okay, so now you see So heart rate's way up and it goes down, blood pressure drops, okay? And then the EEG is blue for a little while. And I'll just fast forward. And kind of what you see then, I think at this point, the SIVO was increased. So we got this period of burst suppression. It's just flat for like, 3 or 4 minutes. And yeah, interestingly, the heart rate and the blood pressure, they never really fully returned to baseline through the remainder of, what is probably up a half an hour, 45 minutes of this surgery. So that's really unfortunate. That's an avoidable error if the EEG had been used. And I'll just mention, if you go into an adult OR, you'll see burst suppression all the time. Just put it on and like, it's just blue, So, okay, here's a 19-year-old coming in for endoscopy. And so this should be take 20, 30 minutes. All right. So he's got a history of aggression, larger patient, also routinely taking anti-epileptic medication. So that might signal a higher anesthetic requirement, right? Because this patient might clear the drugs faster. But it's a short case. So oral pre-medication with ketamine and midazolam, induction of propofol with 1 mg per kg, but then the infusion is like, it's enormous, like 350 mics per kilo per minute. I mean, that's like a really high maintenance. And then, so again, prime directive, we couldn't do anything during the case. So they, the folks in the endoscopy suite called us afterwards and was like, hey, can you put that thing back on? We need to figure out what's going on with this patient. And we're like, no, we're long gone, sorry. But we did analyze the data. And here's what we saw. So, yeah. So here's the ketamine and midazolam, right? So they work together. Again, NMDA antagonist with a GABAergic agonist kind of makes this pattern. So here's the induction dose, and you get slow and alpha. And then the infusion was at 350 and it turned down to 200 here. And the anesthesiologist is not looking at EEG, but look, it's just flat the whole time. I mean, this just, it's like 12 minutes, right? Like so unfortunate. And you see this all the time. This is just like endemic in the OR. And then they don't really come back even after the propofol is turned off. And again, this is a 2-hour delayed emergence in the endoscopy suite. Poor kid. So, but the hypothesis was, all these things related to autism, that this patient needed more anesthesia. So actually we analyzed autistic children in cohorts. So we compared them to neurotypical children. Here's age as a function of in years on the x-axis here. So we compared neurotypical patients with ASD patients. And then what we saw is that in those teen years, the alpha waves of these ASD patients are actually smaller. So if you put that together with the earlier stuff in the presentation, small alpha wave, more likely to go into burst suppression, just like those old adults. So it kind of makes sense. And what we did actually see in this data was that the ASD patients had a higher probability of being in burst suppression, even though they were getting about the same amount of propofol in these endoscopy cases. I don't have a Walsh. Okay, Walsh 2018. Okay, here's another one. Do we have time? Maybe, let's, actually, let me just skip ahead. So this patient, all right, 0.7 MAC, hey, that's a low MAC fraction, right? Okay, fine. But they're actually in burst suppression, right? Suppression, right? Flat segments. And if you believe this indicator here, have been in this state for at least like an hour or so. All right, burst suppression's everywhere. All right. Okay, so now I've been telling you things that suggest you should turn down the anesthetic. All right, but obviously there's a limit to how far that can go. So here's a case of an awareness. All right, a liver failure patient. This is obviously a complex surgery. It's long surgery, and with liver failure, you might think that they need less propofol. Fine, but you really should pay attention to the EEG in that case as you're turning things down. So here is the frontal spectrogram. I don't have the original data from this. This is actually just pulled from a poster that we helped to prepare. And so you can see here, at some point, the slow oscillation is pretty small and there's no alpha wave. And this is for about 100 minutes, okay? So this was a case of awareness. So if I was a betting person, I would say, hey, that's probably when the awareness happened. And then thereafter, the alpha wave comes back. Now you'll note The alpha wave is small in this patient, right? This is a sick patient, okay? So, maybe their prefrontal cortical function is not that strong due to their background illness. So here's what you do in these older, sicker patients, okay? At baseline, they're gonna have a barely visible alpha wave, all right? You turn up the scale, right? You adjust the gain on the spectrogram display and also on the waveform display. You adjust the gain so you can see the signals, all right? That's all you do. You will encounter patients that don't even have an alpha wave. For them, you got to rely on that slow oscillation, all right? But you can still use it in that situation. It's better just relying on a number between 0 and 100.